Good afternoon, everyone. Now we are here to begin with our next session, which is on aesthetics, microneedling, and radio frequency. I would request Dr. Shomajyoti Chandru ma'am, who's a renowned dermatologist practicing at Medica, has over 20 publications, various presentations, and authorship, has various awards to her name. Ma'am, can you please carry forward the session?
Thank you, Dr. Sulbi. Good afternoon, everyone. With delaying much, I would like to call the speaker of the session, Dr. Sachin Verma, who is the Chief Dermatologist and the Medical Director of Skin Vita Clinics, Kolkata. And he's also the consultant at Apollo Kolkata. And he has a wide range of interests ranging from clinical to aesthetic dermatology. And he's been a trainer at various regional, national, and international conferences. So with a huge experience in aesthetics, I would like to call Dr. Sachin Verma to start his session.
Thank you so much. It's absolutely an honor to be here with all of you. And it's so heartening to see you on Sunday afternoon, spending time for academics. And I'm really thankful to IIDVL West Bengal and the scientific committee for inviting me over to speak on this important topic. And thanks to all the organizers who have organized this so well. With that, I would straight away like to share my screen and then go for the presentation. Let me share my screen, please. Yes. Yes, so this is where we start. Is my screen seen? I guess so. Yes. Okay, right. So I have no conflict of interest regarding this talk, and I will be presenting on microneedling radiofrequency. Now, microneedling radiofrequency is a relatively new procedure in which radiofrequency energy is delivered deep into the skin with minimally invasive microneedles. We all know of radiofrequency energy, and we use it on a daily basis in our kitchen, where radio frequency energy is used in microwave to heat up the food. And this is basically a radio frequency energy, and we know that radio frequency energy heats up anything where it has been given to. So anything which, when a radio frequency energy is delivered to a tissue or to a place, it will heat up the deeper tissue. And that background has been used in a radio frequency for application in skin. The only difference here is radio frequency energy heats up the skin very, very quickly, and therefore controlled radio frequency damage is required to have a good result. We have various kind of radio frequency devices, and the earliest radio frequency device I used in my life was a Dharma India, radio frequency needle, where we use for removing of moles and warts and things like that. Now, so many residents and people ask me that how is it different from the radio frequency microneedling that we are using, and how is that very different from what we are using now? So we must understand that all radio frequency does the same thing. It converts an electrical energy to a heat energy or to an energy which can be delivered. In a radio frequency surgery, the entire energy is delivered to a probe which is less than 1 millimeter in size when we operate by a radio frequency device. Because of the probe being so very small, it just cuts the tissue. Whereas in bigger radio frequency devices where the probe is bigger, that entire energy is being given to a bigger probe. With that having said, it heats up the tissue. So in a very, very tiny, imagine 10 joules of energy being delivered with 1 millimeter of probe, you will actually cut the tissues. Whereas in monopolar radio frequency, you have a bigger probe and that going in and heats up the tissue. So depending on the size of the probe and depending on how the energy is being completed, you would have a different result with a radio frequency device. Among the devices that are available with us is monopolar, bipolar, multipolar, tripolar, and so on and so forth. Now, monopolar is the best device in terms of heating because there is no end plate required. It just gives the radio frequency all the devices, the microwave is a monopolar device. It just gives heat with no end plate. It will give as much as the machine is on, it will give heat. The problem with monopolar devices is that it really heats up the tissue and there is no control mechanism with us. And that is why monopolar radio frequency, though is the strongest radio frequency, gives the best tightening effects, is not very popular because we don't have a control over how much energy is being delivered. Then came bipolar, where the circuit gets completed between the difference between the two plates of the hand plate or the two plates. And then came the microneedling RF, where we deliver the needle right into the skin where the energy is needed. So it is more specific radio frequency compared to a monopolar, which is not that specific. A bipolar is specific, but it delivers only between that circuit. Whereas a multipolar has multiple nodes, so it jumps from one node to the other and it heats up at various levels, again, not very deep. The advantage with microneedling is you can deliver a heat deeper and you can deliver the energy that is required at the level that you want. Now, there is a lot of debate about insulated and non-insulated needles. Let me tell you, even in insulated needles, the lower portion, which is not insulated, is about 1.5 to 2 mm. Above that is insulated, because that amount of energy, that amount of space is required to actually deliver the heat. It is not just at the tip. It is about 1 to 1.5 millimeter, which is not insulated, even in an insulated needle. And we are working at 2.53 mm. So it really, in Indian skin, it really does not matter because we are not going 5 mm deep. When you are doing it for, say, underarm, hyperhidrosis, that is where insulated, non-insulated needle really makes a difference when you're going that deep. But when you're going 2 millimeter deep and your 1 millimeter is insulated, 1 millimeter not insulated. So there is a debate about this is more of marketing than actual, but yes, there are insulated and deep insulated and uninsulated needles. Uninsulated deliver heats right through and through, and insulated only at the tip at about 1.5 millimeter at the tip. So MNRF is a bipolar radio frequency which gives energy between 2 points, which goes through the tissue and deep beneath the skin. This heats up the tissue. A CO2 laser and an MNRF actually are complementary to each other. The reason being that, if I will explain you in your slide, they work at different depths. So you see a CO2 laser actually causes more of superficial heating, and a microneedling fractional RF probably gives a volumetric heating. Though there are proponents who say that they can be done in the same session, but I think you become more aggressive if you do at the same session. And if you are practiced enough, like in some patients, we do in the same session also. But if you are not in a hurry, then you should do that in separate sessions. So as you can see that when you do an MNRF, it causes a coagulation zone. And this coagulation zone depends upon the exposure time. That means that how much depth is one and how much energy you are delivered, because the time is equal to the energy delivered. So suppose you are delivering energy for 200 milliseconds, you will deliver, say, X amount of heat. But if you deliver for 400 milliseconds, you are delivering X into 2. And if you deliver for 600 milliseconds, it is like a microwave. If you are heating a tissue in microwave for 10 seconds, it will heat up to a certain extent. If you heat up for 30 seconds, it will heat up more. So the timing is very, very important in terms of a microneedling RF. And as we know, it can regenerate collagen, it can cause collagenesis, neocollagenesis, release of growth factors, and so on and so forth. This is a slide where it shows thickness of epidermis and dermis, thickness of dermis more because of MNRF. Various indications that I think Somdoti will actually cover it. The type of the needles, insulated, non-insulated, again, I said it can be debatable, which is better. According to me, it makes no difference at all. According to me, it's just a marketing gimmick. If you have an insulated, the company would say, oh, non-insulated is better. I have worked on both, and it makes no sense for me to understand how it differs from one to the other. This is the screen of a typical of a RF device, and this is important for people to understand and what this screen is. So if you see on the top, there is a 25 pin. Now you get 16 pin, 25 pin, 49 pin. 49 pin becomes too aggressive and painful for Indian skin, and I think 16 pin is too small. So I think 25 pin is ideal. It depends on how many pins are there in that. If you have a 49 pin, you can cover larger areas, but then it becomes difficult in area around the eyes and the nose where it is really difficult to treat with a big spot size. So 25 pin, you will have to, cover more spots, but that's fine. Then comes intensity. What is intensity? Now this is important. I will come to it in the next slide. Then comes the RF time. The depth, we all know at what depth is the scar. Mode is whether you want to have a single pass or a double pass. If you want to have a double pass, then you have to select double here and then the delay time, meaning you keep the probe there fixed and then keep your leg, keep pressed. So the second pass will be immediately after the first pass, after that delay time. So this delay time, I believe, is useless because you can choose your delay time. Why should you rely on the machine? You pass one shot. If you have to fire after 5 seconds or after 1 second, you fire a second shot. So delay time, allowing a machine to fire a shot, a lot of times you are not fast enough to shift the handpiece immediately in other area. And then therefore the machine, it gets superficial heating. So delay time and mode has to be single. This is useless. For the other things, I'll explain to you how to select it. So first comes the intensity. The intensity there, it shows 40%. Now what does intensity mean is every machine have a power. And I have a device which has a power of 25 watts. 25 watts, if you are selecting an intensity or 25 joules, watts is equivalent to joules here. If you are selecting 40% energy, that means you are delivering 11 joules. That is 40% of 25. So if you are selecting 50%, you are using 12.5% joules of energy. So it is like a hair removal. You should know how much energy to give. Normally, you should start with something like, depending on the depth, with about 9 to 10 joules of energy and gradually build up over the sessions. Rather than straight away going for 80%, 60%, you will cause deep heating and burns. The problem with RF devices is that if you cause overheating, instead of stimulating the collagen fibers, it's going to cause rupture of collagen fibers, leading to atrophic scars. So MNRF is a double-edged sword. You can't just go on heating and causing necrosis of the fiber beneath and causing deep necrosis leading to atrophic scars. So an MNRF has to be treated with the right depth and the right joules of energy. So intensity is what is 40%. If you have a 30 joule and 30 joule machine, so you have to find out from your literature how much joule is your machine. If you have a 30 joule machine, then 40% of that becomes actually about 12 joules or even more. Or you have 15 joule machine, 40 joules only 40% only becomes 6 joules. So you should know what machine you have for the intensity to choose the right intensity and right energy. Again, pulse duration, as I told you, is the time that you are delivering the energy. Normally 200 to 250, 300 millisecond is good enough. Anything beyond 300, you're going to damage it. You should more control it on the joules rather than the time. The time you should keep it constant at 200, 250 at that depth. As you come superficial, then the time should reduce. So as you come, say, an epidermis 0.6 mm or 0.8 mm, then this time should reduce to, say, 50 milliseconds or 80 milliseconds or 100 milliseconds, because superficial heating will cause pigmentation. So as you come superficial, the RF time should go on reducing. As you RF time should go on increasing. So this is how you select the pulse duration, the RF time, the depth, and the intensity. These are the only 3 things in your control. So if there is a deep atrophic scar or something like a keloidal scar, you want to break the fibers of the keloidal scar, you might use 600 milliseconds of delivery time. You want absolute destruction of the tissue there. So RF time you can increase in that patient. So it depends on what type of scar you are treating to actually deliver your RF time and the intensity. It can't be always the same. I would require and request you for another 2 minutes for finish my presentation. So my time is finishing, but I would request you, Somditi, to please allow me to continue if you do so. So this is, I think, very important in terms of pulse duration as to how much time that you are allowing your RF site actually deliver the heat that is required to heat up the tissue. The needle depth, as I said, when you are deeper, when you have a deep scar, you should have, so you should make a visual impression about the depth of the scar. So it's an atrophic scar which is 4 millimeter deep or maybe 3 millimeter deep. So I will select a heating time. So you must understand that if you are heating at 2.2 mm or 2.5 mm with the needle, it heats 1 millimeter up and 1 millimeter down. So if you are putting your needle at 2.5 mm depth, it's heating as much as up to 3.5 mm depth, because the energy causes heating in that area. It's not a specific point. So you must visualize the depth and then see what is allowed and how deep it is. Number of passes I've already explained to you. It should be single pass, and you can go it, if you want, you can have a second pass. Normally 2 to 3 passes are required at different depths for volumetric heating, so that you can have a complete heating. 2.5 mm, then second pass at 1.5 mm, then third pass can be at 1 mm, depending on how you see the scar as, how deep or how bad the scar is. Insulated, non-insulated, I've already covered, it is debatable. Advantage is that it causes electrothermal coagulation, and it's a color-blind device. It does not depend on the skin of the skin color. You can heat any skin tissue without having worried of hyperpigmentation. This is what I was talking about. You see an MNRF, it heats up to 3.5 mm, whereas maximum depth of CO2 is only 1.6 mm. So there is where you can treat it complementary to each other. CO2 works more superficial, MNRF works more deeper. So you can work at both the levels if you do both the treatments. Counseling is important. This is how it looks immediately. I have a lot of photos to show, but I think time is not permitting. But just to explain, this is scars before and after, scars before and after. This is scars before and after, taken from my dear friend Anuj. Scars before and after. So the result is 58% moderate improvement and good improvement in 9% patients. Complications hardly any, especially if you are using it superficial, then there are complications. This is one of the complications where you see this continuation marks, because they have been dragged. So you can see this typical needle-like marks being dragged because of that. Otherwise, it's a safe procedure. You can combine it with subcision. And this is a challenging case. These are the cases where you have to combine all the modalities. So these kind of patients we love treating, because this is where you need to do a lot of MNRF, CO2, subcision, punch excision, and all that to have good results. If I get time, I'll be able to show the results to you post-wise. It can be combined, not so much with acne scars, but in aging skin with sublative RF, especially for aging skin. Because sublative RF, you require superficial tightening for the collagen regeneration. Again, one of our patients with MNRF after 4 sessions for skin lift. After 4 sessions for skin lift, you can see how wonderfully the nasolabial fold has got lifted with MNRF alone, if you do it properly in that area. Again, you can see that MNRF causing the lifting on the nasolabial fold. And again, this lady along with HIFU, so you can combine it. She had a little wider, sidelines, and we had to bring that shallower along with MNRF. So you can combine with HIFU, you can combine with sublative RF, you can combine with CO2 laser, you can combine with PRP. I think it gives very good results. You create micropores and surface PRP on top of it, massage PRP down there. So it goes in through these pores and you get excellent results combining with PRP or even with hyaluronic acid. So you can combine it with PRP for excellent results. You can combine with mesotherapy, that is with hyaluronic acid and vitamin C, especially in cases of pigmentation. And you can see you can combine it with peels. So a tightening along with peels gives rise to excellent looking skin. So you can combine with peels. In case you are combining with fillers, then MNRF should be done first and lastly the filler. Because if you do filler first and heat up the tissue, the filler will get dissolved. So you must do MNRF first. With Botox, it does not matter. But again, I would suggest if you're doing Botox, then you must do the MNRF. You know what wrinkles are remaining. So less Botox is required compared to what you would require otherwise. So with that, thank you so much. And it was a pleasure speaking to all of you. And I hope I could clear some concepts to all those who are listening. MNRF, if you have any concern, you can come down to my clinic to learn and we'll be happy to help you.
Thank you, sir, for a very extensive presentation on the basics of MNRF, which was very, very informative. I would so can you see my screen? Is my screen visible now?
Yes, ma'am. Yes, ma'am.
So I would carry our discussion forward and begin our panel discussion. And I would like to introduce my panelists, starting with Dr. Sachin Verma, sir, who has already been introduced. There is Dr. Abhishek Dey, sir, who is Associate Professor of CNMC and Associate Editor of IJD, along with numerous authorship, publications, and he's a very renowned name in the dermatology and aesthetic circuit. Then I have Dr. Ishad Agarwal with me, and he's a consultant at Medical Hospital and Wisdom Clinics. And he also has, he's been the trainer at various aesthetic conferences and workshops, etc. And his special interest is in cosmetic dermatology. Now, without wasting much time, I would start my session on MNRF, and it will be a case-based discussion, and we will be mostly discussing on the management aspect of individual cases and how to utilize this technology and device to the best of each indication. And I think that will be an exciting discussion. So I have this patient, a 24-year-old gentleman with a very mixed type of grade 4 acne scars, and there is a hypertrophic nodule also that can be seen on the left side of the cheek. And we would be discussing how MNRF can be utilized in this patient for the best. So I would start with Sachin, sir. Sir, will you take up this question?
Yes. What is the question? How many sessions and what?
Yes. So how will you utilize MNRF in this patient? And how, of course, we all know that acne scar requires a multimodality treatment approach. It's not only MNRF. If you are using MNRF, how will you use other devices or subcision or a TCA cross? And how will you place it in the treatment regimen of this patient? This type of patient with a very deep and mixed type of scars.
So the biggest challenge in dermatology is that the patient wants result in 4 or 5 months. You cannot ask the patient to come for 2 years for managing acne scars. And if you try to do only MNRF first for 6 sessions, then you do okay, now I'll do CO2, then I will do subcision. What happens is the patient tends to lose patience, and you tend to lose interest in the sense that patient feels that it's not working out. It's not, the doctor is not qualified enough or is not competent enough. It's not working out. So what you need to know is you need to first make a treatment plan with the patient. Okay, in how many months do you want to look better? In how many months do you want your acne scars to improve? And that treatment plans become then your Bible to treat the patient. You have to understand that this patient has multiple scars. He has a bad scars on the face. He will require subcision. A subcision is a deeper treatment which can always be combined with RF because it is not a heat energy, it is a traumatic energy. So when you are giving 2 different forms of energy, there is no problem. So every session I would probably do subcision to all his scars which are deeper, so that I cause collagen regeneration in the areas which are deeper and deeper scars. I would do microneedling RF, maybe 6 sessions, 1 session every month. I might combine it with a peel before a microneedling, which will cause superficial improvement. So I am combining multimodality treatment, maybe charge only for 1 treatment. But I will combine multimodality treatment because in 6 months, I would have not only surface improvement, deep improvement, and the acne scar improvement, If I am doing microneedling RF, then I would probably have 2.5 mm depth, then depth and 1.5 mm depth and 1 mm.
I'm sorry to interrupt you, sir. Technical team, please look into the matter. There is a lot of yes, please mute the unwanted. Thank you. Yes, sir.
I would probably, heat at 2.5 mm or 2.4 mm first pass, second pass at 1.5 mm, third pass maybe at 1 mm or 0.8 mm, give volumetric heating, do a subcision for the deep scars, do a peel if required, do this every single time the patient is coming for 6 months. And if I did not get time to show my acne scar results, you will be shocked with the results. You would see that in 6 months' time, this has no scars left. And you would imagine, and you have made a treatment plan. So patient knows that he's going to improve in 6 months. If you do only MNRF for 6 months, he will improve only 20%. And then he would come back and say, Doctor, itna paisa kharcha kiya, aur kuch to hua nahi. So that is very, very important that you promise a result in a particular time frame and work towards that time frame. This is how I would treat.
So what needle do you use? I know there's
I use 18 gauge needle. I always use 18 gauge needle. I don't use 26. I always use because I think it's more traumatic, but it causes trauma as desired. If you use a 24 or 26 gauge needle, it does not cause trauma. It is like a blood withdrawal needle. So I always use a 18 gauge proper needle, proper breaking of fibers. Do not worry about a post hematoma or redness. I just counsel them. There will be redness. Don't worry. It is what we actually desire. I don't do.
So if you're combining subcision and MNRF in the same sitting, do you lower the settings of MNRF?
No. Because I am only doing to 3-4 scars. I'm not doing everywhere. And it's a different form of energy. In that we are just breaking the fibers. We are not giving any heat. I told you to start with. That's an heat energy that is stimulating collagen. And this is a traumatic energy which is causing, migration of leukocytes. So it's not working the same way.
Abhishek sir, will you take up this?
Yeah, I kind of agree to most of the things Sarah said. There are a couple of things. The patient still has an active acne, so as a doctor, we should be treating the active acne. For the juniors, I will tell always judge the acne scars. Like she has already told us, is a grade 4 scar, so you can always stretch the scar to see which grade the scar is, and that is very important to note because you can always tell the patient later that see your scar has improved, and not only photographically but also you can see the visible changes. Like Sarah said, you should always have a plan. You should always have a plan how you combine the session. For me, whether I'm doing a fractional laser, whether I'm doing a microneedling RF, any other form of like maybe I'm doing a non-ablative laser, subcision is part of the procedure every single session. So there's no way I'll not do subcision in any patient. Anything. You can see the types of scar also. Not only grades of scar, the types of scar is also important. Yeah. Remember, the most of our devices, including microneedling, including our ultrapulse or any other CO2 fractional laser, tend to affect based on the rolling type of scars. But it doesn't affect that much on the ice-pick scars. Doesn't affect that much even the box scars. So what you need to do first, some of our box scars, if you see in the very first session, you can convert them into a more rolling scars. You can use any other ablative devices like a ablative radio frequency devices, or what I rather do, I use this. I have this ultrapulse CO2 fractional laser that has an active FX mode, which is a superficial mode. I make it higher concentration at that. So turning into a fractional laser into an ablative laser, but the penetration is controlled by the active FX mode is very superficial. Then I usually border the surrounding of the box scars so that in 1 or 2 sessions these box scars are converted into rolling scars. That is something you can do. If the ice-pick scars are, trust me, most of the devices we use do not give that good results. So you have to include cross some. I usually don't love to do cross in the same session with the lasers. You know why? Because after the lasers or after the MNRF, there are a lot of erythema. So you do not actually see where to put the crosses. So I usually call the patient in between the session, and I do 1 or 2 or 3 sessions of cross in between this thing. I do not use 100% TCA for cross. So I use about 50% or 60% of TCA or 70% of TCA for the crosses. And but this is possibly the only thing gives you some amount of recovery from this, ice pick cut. So it's idea is there's no single modality of treatment. We have to do a lot of mixing and matching. You have to assess all of our patients differently. Coming to MNRF, so there's a debate about the insulator and non-insulated needle, and rightly said that possibly there's no differences. There's another reason why there's no differences. If you see, even if you are using a non-insulated, there's an impedance grading is there. The epidermis is higher grading and dermis is lower grading. As for any electromagnetic wave, it goes from higher impedance to lower impedance. So even if you are giving a non-insulated mode, automatically the electromagnetic forces go from higher to lower. So more delivery will be toward the tip of the needle and not toward the base of the needle. So it doesn't actually make a much of a difference between choosing a non-insulated or insulated modality. And moreover, we cannot buy 3-4 devices of radio frequency. So we possibly will have 1 or 2 devices to carry on with our practices. So if we have an insulated device, we have an insulated device. If you do not have non-insulated, be so, use that, but learn to use that in a right way. One important tips for using a microneedling RF, be vertical. The problem with microneedling RF happens if you casually put the radio frequency, you have to give the full penetration of those things. So those are like, very, unlike laser, my MNRF is little bit of, user dependent. So that is something you need to be taking over. I do not love to give same 3 or like, for this car, possibly I'll use a 2.5 millimeter and 1.5 millimeter, 2 passes, different needles.
Yep.
And about 6 sessions, as said, 4 to 6 weeks intervals. So that's how possibly I'll be doing. Energy differs between the kind of devices you use, roughly about 12 to 15 millijoules. That's how I start this kind of patients.
And that is for the cheek area, sir. So what about the scars on the nose or the central forehead?
Possibly I won't be using the 2.51. I'll be using only the 1.51 because of course the scar depth is also limited. So that's how I'll be doing. You should be a little bit, agile, and you should be addressing individual patients and not like there can be a set parameter for any scar reduction.
So what needle do you use, an insulated or a non-insulated?
I use a non-insulated because that's the only, my device only has non-insulated. So, I have 2 devices, both unfortunately both as non-insulated. So I never used an insulated device.
So if we are using a non-insulated, there is no insulation. So as histometric studies have already proved that insulated needle produces a oval zone of coagulation just around the needle tip, and a non-insulated produces a more columnar or a vertically columnar zone of coagulation. So what is the rationale of using a double pass if you're using a non-insulated needle?
Very true, very true. Possibly we do not require also, very true, but that's why I said there's an impedance grading. So when you use a 2.5, then majority part of our energy tend to be at the later part of the thing. So your middle part is not getting that much of energy. So if you can top it up with a lower fluence, smaller energy needle, then you tend to get a better result. That's my personal experience. That's how I think about it. But I agree the scientific point of view, possibly you may not require 2.5, but that's how the standard protocol is, and I find rational because of this impedance gradients.
Humduti, can I make a small comment?
Yes, sir.
This comment is, I think we will now allow after this learn everybody will learn from Ishad after that. I have not learned from Ishad today, so we'll allow Ishad to speak after this. But importantly, what I wanted to make a small point was that in insulated versus non-insulated, the question that you asked, then what is the point if we are doing it at multiple heatings? If we are using insulated, if we are using non-insulated needle, then the energy is actually going everywhere. So what is the use then of using insulated needles at all? The reason for that is that in insulated needles, you exactly know how much energy you are delivering at what level.
Yes.
In non-insulated needles, we don't know because the energy is being lost throughout. So though it is heating at all the levels, we don't know at 2.5 mm depth how much energy is being delivered. Now that is a challenge but that is at a level where you want to really do studies. At the practical point of view, if you are heating throughout the tissue and not burning the skin, it really does not matter if you know how to use with the machine. So technically it is important, because in an insulated needle, if you pass 11 joules, the 11 joule will only reach at 2.5 mm and deliver 11 joules. But in non-insulated ones, you don't know how much is being delivered at a deeper level. Yes, please go ahead with the next slide.
So, Dr. Ishad, when you're dealing with this kind of a very deep and mixed type of acne scar, do you combine PRP with consider even combining PRP?
So there are two things about it, Somjyoti. Already, you have to look into affordability of the patient as well. You can't just randomly suggest, say, do 6 sessions of MNRF, 4 sessions of CO2, and then add PRP at every session. Yes, if my patients can afford, why not? I would want to give them better results. Yes. If you have to use PRP along with MNRF, I personally do not like to spray it on the face and then do an MNRF on top of that. I like to inject it intradermally rather than just spraying it. But yeah, you can combine PRP with MNRF. There is absolutely nothing that you wouldn't want to do.
So injection is always better.
If we are doing a subcision where there is a hematoma formation, there is PRP. Sir, what is if we are doing subcision with MNRF? Do you think adding a PRP would give an additional benefit?
Look, so are you only considering the acne scars? Yes, then maybe you might just, if you're creating a hematoma with the subcision itself, might suffice. But what I tend to do is I tend to give people more global improvement and not just the scars alone. So like I said, depends on what your patient is actually looking for. If they're also looking for some tightness along with that, they're looking for a more global rejuvenation of the face, I would definitely want to add PRP.
Somjyoti, maybe can I answer this?
Yes, sir, please.
Yeah. See, I take your point. Not why you have to think about subcision, you also doing microneedling. So that is also causing local hematoma. But why PRP is doing, but just because in GK you are doing an injury, that means there will be platelet release, but that may not be platelet reach. Platelet reach has a definite definition, and Max has studied that when you reach about 10 lakhs and beyond, then only your PRP start working. So just because you have a hematoma, that doesn't mean that you have a good healing. And studies has also suggested that if you combine it with any ability, fractional lasers, and if you see fantastic paper with fractional CO2 laser, fractional RBM laser with PRP, they have shown with split face studies that there's a better result, definitely. So if you can combine with PRP, MNRP, possibly you have an edge. But at the same time, there's a pocket is also an issue for most of our patients. What I find, if we can combine, then the healing time, that's the downtime goes down, and your healing is almost PIH free always. So that is something as always noted when I can combine PRP with any other fractional devices. I've not done it in MNRF, but I've done a lot of patients with CO2 fractional with PRP, and the results are definitely better.
Sir, I was just talking when we are doing a subcision on the same sitting as MNRF, like if we are combining sessions, like if you're doing subcision plus MNRF plus a PRP in the same session for the patient, how rational that would be. Thank you, sir. So this is just a rough guideline on the needle depth according to the facial area that is to be treated, because needle depth has to be changed according to the anatomical area, the bony prominences, etc., etc. So coming to my next patient, a middle-aged lady with a very prominent sagging and a very prominent nasolabia and melomental folds, and she's not very comfortable with taking injectables. Can MNRF be of any help? Ishad sir, please start.
Start with whom?
Ishad sir.
Okay.
I know he would inject Botox and fillers, so I would.
Look, if I have a
you
patient,
are the wrong person.
That is right.
If I have a patient like this, I would first not just think about MNRF alone. Honestly, I would first want to maybe do HIFU first on her, and then maybe do RF for her, because she's got a more sagging kind of a face.
Yes.
And MNRF or RFs in general is more suitable for a more thinking kind of a face, number one. So there are certain areas on her face which are of course thinkers. So I would definitely avoid the mid-face with HIFU for her. And with the MNRF, what we are really looking at is improvement of, you can see some static lines on her forehead.
Correct.
That is where I think I can deliver some improvement. I can definitely improve her under eye a bit, but I wouldn't really promise her great results with her marionette lines and the nasolabial.
Nasolabial.
But most important here would be to really assess what is it that your patient is looking at. They might say, we do not want anything artificial, we only want something natural, and then they will come and do this, that we want this whole thing to go up. So understand what they're looking for, because they might come after say 6 sessions saying that, my line is still there. So that is one thing, but of course you can definitely deliver an appreciable change in these kind of patients after say about 6 to 8 sessions. Do combine HIFU for somebody like this when you're doing
the first session will be a HIFU or a bipolar RF?
Yes.
HIFU. Okay.
HIFU.
Yes, sir. Sachin sir, you have showed us a.
I will tell you, this is a patient which really requires a filler. You see, the point is you have to not listen to the patient all the time, because in the end of the day, you see 6 sessions of MNRF would probably not even produce 30% of a result what would be produced by a single filler or maybe 2 fillers.
Yeah.
So there are 3 kinds of aging skin, wrinkler, sagger, and sinker. That's how we actually divide the skin, sagging skin or the old skin. Wrinkler is something which wrinkles too much on the face. Whole face is filled with wrinkles. Wrinklers are one which benefited by sublative RF or MNRF. Saggers are one which gets benefited by HIFU and by fillers. And, the wrinkler, sagger, and what was the third one I said?
Sinker.
Sinkers are the one which will be, required for filling up. So this is a patient which is a sagger. So you have to lift. Unless you lift, so the lift is by the fascia lifting. So as rightly Ishad said, this patient requires a HIFU and a filler. If she is not comfortable with injection, you have to tell her that if I am the one, I'll tell her, okay, fine. I am going to give you a choice between 25 needles 50 times at one session vis-a-vis 2 needles under local anesthesia, under occlusion. What would you choose? The cost would be same. So it is also how you counsel. Microneedling is full of needles. Yes. It's not without needles. So if you say that patient doesn't want needle insertion, no, she should take in needles because it's less than, microneedling RF. So these patients need a filler and a HIFU. I don't think she's a candidate for MNRF at all.
So she has a prominent double chin also. What is the experience of MNRF?
That's why HIFU will be good choice for this patient. So what I have been doing, I'll be asking her for a couple of sessions of HIFU at 3 months interval. That's how I'm doing now, because one session of HIFU, it doesn't give me that good result these days. So I'll be putting them into 2 sessions of HIFU at 3 months interval, and then ask her for fillers. See, there you have to understand where the problem lies. It's a mid-face volume loss. Typically, the patient may have other issues, like maybe the bone has reduction has happened. Maybe the patient has vitamin D3 low. So all those factors have to keep in mind. If there is a volume loss happening in the mid-face, how much skin tightening you do, it's possibly doesn't give. Rather, the patient seems to, for her age, seems to have a good tightened skin. Doesn't have too much of fine wrinkles and lines. So, I would rather counsel the patient not to go for my MNRF. If at all needed, maybe I'll be doing a sublative sort of things, but not MNRF for sure.
Going on. Periorbital rejuvenation. Can you use MNRF for this? And how? Ishad sir, we'll start with you.
I would, you can use MNRF, but here I would, want to inject a skin booster after that, after a few sessions of MNRF, not just MNRF alone.
Can I make a point? Periorbital rejuvenation is a huge topic. There's not a single type of periorbital. You see the couple of photographs you have given is completely different. The upper one is more, Caucasian. Patient has fine wrinkles around the eyes. Patient possibly did a lot of Botox for lower eye, typical tear trough Indian skin. So, possibly patient needs a fillers. So these are a lot of different things. If you have fine wrinkles, like I have. You can see my eyes, so you can see a lot of fine wrinkles in and around the eyes. Possibly these are the client when you can do a little bit of MNRF, but this is when PRP combination with PRP can be excellent. And Ishad can vouch for that. He had conducted a study for that also long back. Possibly he has forgot also, but he had done his microneedling, normal microneedling with PRP. That is an excellent way of delivering that kind of periorbital rejuvenation who has fine wrinkle around the eyes. So that thing can be done. And some people have just dehydrated,
sunken
eyes around that shrunkening, and those people also can be benefited by this because of the collagen tightening happens. So
I think first the photo on the top left corner, that patient has static wrinkles and very superficial type of
maybe you can use over there. But the patient also need a Botox. He has
yes,
lot
definitely,
of
definitely. The Botox is there, and it is a multimodality approach. Few sessions, and the lower part will require a few sessions of heels as well to take care of the epidermal pigmentation part. But how should we use MNRF in these patients? Sachin sir, your patient.
Yeah, so I think this patient requires multimodality treatments. As I said, Botox, Mesobotox, MNRF, PRP. And I think counseling and telling them that we can't give results. Complete results is not possible. The right expectation is giving the realistic expectation to the patient. In a under eye rejuvenation at max with all modalities combined, I only promise, except for the crow's feet, it is different. We can almost promise 90% reduction of wrinkling with Botox. But leaving crow's feet apart, the other area I maximal with odd modalities put together, I just give 50% improvement over 6 to 8 sessions. And that what session you would choose, whether a PRP or a microneedling RF, or simply a derma roller, or maybe something else, maybe a derma pen, would actually depend upon various factors. What is comfortable to the patient? What do you think is going to work best? Even a simple derma pen in this area can work well, because a derma pen can actually deliver a lot of actives, and it creates the right hole at the right depth without causing the burning. So I would not want to deliver too much energy under the eyes. I would rather use derma pen in this patient. Maybe use once in 15 days, 6-7 sessions. Maybe use a Mesobotox. Maybe use a PRP. Add a Botox on the size of the crow's feet, and maybe an MNRF if it is required at only few areas, not at all the areas. The lower patient requires a filler, a tear trough filler, and that's it. One good tear trough filler is going to solve her problem, the lower patient.
So if you're doing MNRF for this patient, what should be the needle depth and the energy level?
So a needle depth under the eyes should not exceed 1.5 mm. So you start with 1.5, 1 and 0.6 or 0.8, depending on, so I always give 3 passes, because I think 3 passes gives volumetric heating. So when you're using, say, something like, 1.5 mm depth, then I will use an energy like 25% or 30%, which is about 8 joules or about 7 joules. Then go down to 5 joules and 4 joules, then 1 mm and, 0.8 or 0.6 mm. And have 3 passes in the same area, and maybe combine it with a PRP, injectable PRP in that area in the same session.
What is the reaction RF time you use for under eye area?
In such patient, the first pass would be at 150 millisecond, the second pass will be 100 millisecond, and the third pass at 80 millisecond.
Yes, sir. Abhishek, sir, you were saying something.
No, it's fine. Just one thing I just wanted to add. I possibly will not be even using 1.5. Possibly I'll be using 0.5 and 1, 2 passes, because I usually don't give 3 passes. I'm a little bit more less aggressive, I would say, from Sachin sir. Maybe with his experience, I'll also someday be using 3 passes. One thing I must say, though it is less commonly used for our kind of periorbital rejuvenation, but it is one of the first indication microneedling RF got its license for. This is the reason why MNRF got the license for in 2002. So that's something we need to keep in mind.
So would you like to use a sublative RF for the under eye area?
That I can use. Of course, it doesn't give you that much benefit.
Great response.
But it can be, a lot of people doesn't go on to the, ablative or any injectable, any painful procedures. So sublative RF is always good for when you don't want to do anything else. So it can give a tightening, especially younger people. It's cannot work too much on when the people has, kind of very old. Younger people and people who has under eye bulge. That's when your sublative RF can be a good options.
And when we are dealing with the under eye area, your treatment sessions are 1 month apart, 4 week apart? Or
I tend to under eye. I tend to be little bit earlier. It's like 3 weeks. I usually do for about 6 sessions. That's how I usually target. One thing, this area, the healing is pretty fast. Though it's like area which we usually. So healing is very fast.
So you have to be very mindful of the hematoma or bruising that can happen over here.
Yes.
yes.
So people who are taking a lot of green teas and all the people who are like very fitness maniac, aspirin, we need to keep those things in mind.
So if you see the patient on the upper, the first patient, you actually are able to see a vein that is there. So it's important to look for these kind of structures when you're actually treating this area, because you can actually land up with a lot of bruising.
But
also
Ishad, one point I want to make here, which I want to tell all the residents also. We are working at 1.5 millimeter, for God's sake. The vein is at 5 millimeter and 4 millimeter below. So we are working at 1.5. We are not even crossing the dermis. So if you are at the right depth, that may be relevant for filler and Botox and things like that, but not relevant for an MNRF, because MNRF, you are working at 1.5 mm. You are not even crossing a full thickness dermis.
The bruising
this area
would be with the capillaries, not with the veins.
Yeah, even the vein or the capillaries in the epidermis and dermis, there is hardly any zone where you are going to cause it. Maybe a little bruise at max, not anything more.
Yes.
Yeah, bruising.
And anyways, skin with a very high laxity, particularly the upper left corner patient, the skin tends to bruise easily.
This area typically bruise a lot.
Yeah.
This is all for capillary bruising. Of course, it's a capillary bruising.
That will have a downtime. That I think the pre-procedure
about 2 weeks. About 2 weeks. So anybody has a social gathering within 2 weeks, you should not be avoiding those.
Or use a concealer. I think that very well gets.
Yes, green concealer is very good.
Yeah.
Surbi has written, the time is up. Try to cover fast.
Yes, sir. Most difficult. Sachin, sir, would you like to? How will you like to deal with this patient? Hesitation for both physician and patient.
I think tough. Hesitation as a doctor is a must.
Yeah.
So don't promise. Don't over.
So both are my patients. One is in the forearm, and the other is in the thigh.
Yeah. What is she doing on the thighs? Generally, thigh is not very common. But having said that, I think it is important that you do what I treat is I do a CO2 with a PRP or a microneedling RF and a PRP. A combination definitely works. I hope I could show you some photographs if you are in my clinic. It works well. But at max, again, 50 to 60% improvement, no complete improvement, advisable, realistic expectations. It always remains a challenge how to treat this. Even I have tried derm abrasion, proper derm abrasion with a derm abraver, with a multi-motor, sort of derm abrader, but still it is visible. So it is a tough thing to do. MNRF with PRP would be the choice here, or a CO2 with a PRP.
CO2 you use fractional mode or the pinhole mode?
Fractional mode.
How frequent are the sessions?
Once in 3 to 4 weeks. The frequency of session should not change because that is the collagen regeneration time. So before you induce fresh injury, the earlier injury should improve. So
yeah, of course.
It takes 3 to 4 weeks to recover of the last injury.
So usually body skin takes a longer time to heal. So is the session placed at around 6 weeks apart or a little more time?
I completely do not agree that body skin takes a longer time to heal. It is just that we see visually. If microscopically, if you read about skin healing time, it doesn't change from area to area. The skin healing time is same everywhere. So if you read in the textbook, any Rook's textbook or anything, the skin healing time, the processes, it is same in every part of the body. So you should induce a new injury only when the earlier injury has improved, which is 3 to 4 weeks.
Abhishek, sir.
Sorry to interrupt, ma'am. We are running short of time. Could you please wrap up the session?
Yes.
So just one point I'll mention over here. See, any geometric scars like straight line, triangle, circular, it will be always very difficult. Even if you have given percentage improvement like 70, 80% even or 60%, even then it will be visible. So one thing I usually encourage my patient wherever it's possible, I do complete my session and ask the patient to do a tattoo, sport a tattoo on top of that. That's one way of masking these scars. Otherwise, it can be very difficult.
So what about the hypopigmented lines? That pigmentation doesn't match. Even if there is a flattening.
So what you can try, you can, that's why this is one scar I'll possibly do my ultrapulse. You can use the active FX mode that do the visible, I mean, superficial resurfacing. But even if it goes down, then straight line is easily picked by people. So it's socially still getting picked. So that's why you can ask the patient to do a tattoo on top of that wherever is possible.
Sir, I have a question for both of you. So how much improvement would you, tell a patient, because they'll tell you, ask you, this is something that I struggle with. How much would you say, itna percent improvement aa jayega? Aap itna session
this patient in about 6 sessions of CO2 fractional, I can give you a 60% or 55% improvement, roughly.
So carrying on, stretch marks, same way to deal with? Any extra point you would add?
This is one indication I believe possibly MNRF is better than a fractional laser.
So otherwise, you have to use volumetric thickening and the skin laxity will improve.
So the upper left patient is a teenage boy around 15-16 years with a growth spurt stria, and this is a post-pregnancy stria where the skin was totally, totally lax, along with a very, so hyperhidrosis. Anybody using MNRF for that?
I would love to use Botox instead.
Instead, I would do Botox. Yeah, totally.
Sachin, sir?
I have used in few patients and it gives good results. You have to take a 3.5 mm depth. Actually, 5 mm depth is required. But what I do is I take a 3.5 mm depth and press it hard against the skin so that it can penetrate much deeper. And then use a much more higher RF time between 400 to 500 milliseconds.
And energy?
Intensity of 60%.
And how frequently do you have to repeat the sessions?
It does reduce the hyperhidrosis by 30 to 50% over 4 sessions.
Okay. And how frequently are you doing the sessions?
Once a month. Everything is once a month.
Okay. With MNRF, are you still using fractional lasers often?
Yes, combined in some patients.
And sublative radio frequency, your experience?
So I think you can be combined with aging skin, not with everybody, but with aging skin, not so much with acne.
For superficial texturing.
Yeah.
Okay, with this.
And a lot of people wants the tightening. That also in young patient, if they ask for the tightening of the face, and so you don't have too many devices for the lower faces. So this is something you can always choose in a lower face rejuvenation. Like jawline defining, those are the area sublative RF really works.
So what is a bipolar RF vis-a-vis HIFU? If you were
the two are different level. They two works in a different level. So suppose you have a very bulky face, like the patient's photograph you have given, HIFU is better choice. But it has hardly.
Which one to choose?
So if you have a very bulky face, you need to dissolve a little bit of fat and try to reconstruct a jaw. Then, or rather, you plan for a filler. You do the HIFU first, dissolve a bit of fat, and then do the jawline defining with a filler. That is when your HIFU comes up. When you have patient who is like young and model sort of thing, patient already are well built, but some amount of laxity is there in the skin, especially for the lower part. You don't have too many devices to work on, and then your sublative RF comes. So to have a different indication altogether.
Indications, right. Okay.
For a
Thank you.
sinker phase, for a sinker, you need to do RF. For a sagger, you need to do high force. That's how the dictum goes.
Thank you, panelists. Thank you, sir. It was a very, very enriching discussion. With this, I end my session. Thank you, everyone, for a patient listening.
Thank you, everyone.
Thank you so much, respected moderators, speakers, and panelists, for such an exhilarating experience.